Welcome to Mercy Medical Center's live webinar. Today we'll be discussing skin cancer and how to reduce your risk. Joining us is dermatologist Dr. Robert Berry. After his discussion, he will take questions from our audience. To submit your questions anytime during the discussion, go to the window in the upper right-hand corner of your screen and type in your question. If you don't see the screen, click on the orange box with the white arrow. Your questions will be confidential. Well, welcome to the webinar, Dr. Berry. Let's go ahead and get started.
Thank you, Lynn. The purpose of this presentation is to discuss the common skin cancers. We will discuss risk factors for each type of skin cancer and features suggestive of cancer. The diagnosis of all three common types of skin cancer is dependent upon biopsy. Biopsy is easily performed in the office under local anesthesia. It is relatively painless and gives a rapid answer to the question of the presence or absence of malignancy. The diagnosis of skin cancer is not a do-it-yourself process, but developing the suspicion of one may appropriately be so. All three common types of skin cancer are more than 95% curable if they are diagnosed and treated early. Frequently, when told that they have skin cancer, my patients say, "But it doesn't hurt." Pain is an infrequent and very late symptom of skin cancer. Delay in diagnosis complicates treatment and results in poorer prognosis. Therefore, if you are suspicious that you have a cancer, you should seek care as soon as possible. Treatment and preventative strategies will be discussed for skin cancers. The first type of cancer that we're going to talk about is basal cell cancer or basal cell carcinoma. This cancer is thought to arise in the cells of the hair follicles. It is the most common skin cancer, and in a white population, it is the most common of all cancers. Risk factors for basal cell carcinoma are ionizing radiation. The damages of this are cumulative and are never lost. The types of ionizing radiation are ultraviolet light, which is subdivided into three categories or spectrum. The A spectrum, which represents 320 to 440 nanometers, will pass through window glass. They are more penetrating than the B rays, which I'll talk about next. They are the predominant type of radiation used in so-called tanning beds. The B rays are from 290 to 320 nanometers, and they are blocked by window glass. The C rays are less than 290 nanometers, and they are blocked by the atmosphere. For this reason, the A and the B rays are the ones with which we are predominantly concerned when it comes to cancer prevention. For every 100 feet of gain in altitude, there is a 7% increase in the ultraviolet dosage. Reflection also adds to the dosage of the exposure. Ionizing X-rays are another type of ionizing radiation, as are particulate radiation, such as cobalt therapy, welding, and arc lighting. Yet another risk factor is skin color. Caucasians are at greater risk than Hispanics and Orientals, and they are more at risk than blacks. Skin color is characterized by Fitzpatrick types 1 through 6, and the lower the Fitzpatrick type of skin, the higher your risk factor. Type 1 is typically a red-headed, green-eyed Irish type person or a very fair brunette. These people only burn when they are exposed to the sun and freckle, but do not form tan. Type 2 would be a very fair Scandinavian. A type 3 would be an average European. A type 4 would be a darker European, such as a Spaniard or an Italian or a Greek. A type 5 would be mixed blood and skin color, and a type 6 would be a pure ethnic black. Other risk factors having had a previous non-melanoma skin cancer. 43% of all people who've had their first non-melanoma cancer will have another one within 3 years. Diseases of absent pigmentation are another risk factor. Examples are vitiligo and albinism. There are inherited diseases characterized by large numbers of skin cancer at a premature early age, and examples of this would be nevoid basal cell carcinoma syndrome and a very rare disease called xeroderma pigmentosum. Immunodeficiency is a predisposing cause for skin cancer. People with lymphomas have this predisposition. Aging is accompanied by immunosuppression and is another risk factor. There are a group of iatrogenic or doctor-caused altered immune states, such as organ transplant patients, patients who have received ultraviolet therapy, for example, for psoriasis, and patients treated with radiation, and also patients treated with some of the newer immunobiologic medications used to treat psoriasis and other diseases. Screening for basal cell carcinoma is as follows. The ideal screening procedure is one that catches all the cancers. Therefore, it will also include many lesions that are not cancerous and requires follow-up with diagnostic procedures, which should be 100% effective in finding the cancers. Screening involves total body examination of the listed fields. It should be systematic so that no field is overlooked. Screening can be done by oneself, but it is best performed by another person. That person need not be a healthcare professional. Self-screening is best done once a month, but for practical purposes, if done 3 to 4 times a year would be adequate. Suspicious characteristics for basal cell carcinomas are a sore that won't heal within 1 month and or bleeds easily with minor trauma such as rubbing with a towel or a washcloth, a persistent pink scaly spot, a scar-like area with no history of previous trauma or injury to it. Some examples of basal cell cancer are here shown, and this is fairly typical. You will notice that there is crusting of the lesion and that it has a slightly raised border. Dermatologists speak of this border as being pearly, that is somewhat translucent, and it frequently has enlarged little blood vessels in it called telangiectasies. This is another example shown on the nape of the neck, and you can see that it does look somewhat scar-like, and also it has the characteristic of being a persistent pink scaly spot. This area on the back of the ear, if you go back, I'm sorry. On the back of the ear shows scars from previous problems, but the lesion along this area is the basal cell cancer, and there's probably some extension of it into this area also. This area is an ulcerated area, and this is one of the really dangerous areas in that it represents areas which, as the embryo is forming, have cleavage planes formed between sheaths of tissue as they move around, and these cancers tend to be deeper than out on the flat of the cheek, for example. This slide is demonstrative of a fact. This is the basal cell cancer here, but this spot over here is a totally benign lesion which looks somewhat like a basal cell cancer, and it represents an overgrowth of the oily areas of the skin. As you might guess from this, This would be just a persistent pink scaly area and really does not seem to have much depth to it at all. Treatment for basal cell carcinoma consists of treatment with one or more of the following. Surgical treatment may be excisional, may consist of curettage, which is scraping with a sharp spoon-like device, and fulguration, which is burning with an electric needle. Mohs micrographic surgery is a very specialized way of performing surgery on skin cancer, and cryosurgery is surgery by freezing the skin. Another modality frequently used is radiation. For certain selected types of skin cancer, chemical treatment is appropriate, and for example, the medication imiquimod, also known as Aldera, can be used to treat superficial basal cell cancers. Follow-up for basal cell cancer should be for a minimum of 5 years. Squamous cell cancer is the second most common skin cancer, and it may have a precursor lesion called an actinic keratosis, which may also be called an in situ squamous cell carcinoma. Risk factors for squamous cell carcinoma are skin color, heritable problems such as xeroderma pigmentosa, and immune deficiency as in basal cell carcinoma. Other factors that were listed before for basal cell carcinoma as risk factors are applicable to squamous cell carcinoma. Screening is as discussed for basal cell carcinoma. The characteristic finding of an actinic keratosis is a sandpaper textured patch. Frequently how it feels is more helpful than how it looks. If left alone, these lesions result over a 10-year course in approximately 3% of them becoming cancer. Some examples of actinic keratosis are shown here. And you can see that the whole field of the cheek is really showing sun damage, but there are areas which show the rough change that I'm talking about. Here's one on the rim of the ear, and you can see the crust rough formation that they have right in this area. Here's one on the cheek, on the flat of the cheek. And here's another one on the flat of the cheek. Squamous cell carcinoma or cancer appears as a rough textured and or volcano-shaped growth. Some examples would include this lesion, which is in front of the ear, and which you can see would have a rough texture to it, the surface. Here's one on the lip, and these lesions are more serious than those on the skin and have a higher incidence of spreading to distant sites. This is on the top of the hand and is just a moist-looking, persistent growth. Here's a more typical volcano-shaped one on the back of the hand. This volcano has a plug in the center, but they sometimes actually have an actual divot in the center. Diagnosis is again by biopsy. Treatment of squamous cell carcinoma is either by surgery, which is again excisional, or by curettage and desiccation, which is a synonym for fulguration or burning, and the Mohs micrographic surgery. Chemical ways of treating squamous cell carcinomas, one example of which is actually injecting a chemical 5-fluorouracil into the cancer, and radiation. Follow-up, once again, is for 5 years. Malignant melanoma, which I sometimes lapse into calling just melanoma, is a cancer arising from the pigment-producing cells of the body called melanocytes. It's important to remember, however, that they are not necessarily pigmented. Risk factors for melanoma are sunburns at an early age, particularly prior to puberty, having had a previous malignant melanoma, ionizing radiation, for example, tanning bed usage increases the incidence of malignant melanoma by 4-fold or 400%. Skin color plays a part in the risk, and again, type 1 people are the most susceptible. A family history of malignant melanoma in a first-degree relative is significant and is a risk factor. These may represent actual diseases, one of which is the dysplastic nevus syndrome, and another which is xeroderma pigmentosa. Giant congenital nevi or birthmarks are prone to have melanomas in them. Immunodeficiency again can play a part, and the absolute number of nevi is somewhat significant, with people with large numbers of nevi being more at risk. Some types of melanoma are lentigo maligna of Hutchinson, also known as the Hutchinson's melanotic freckle. Later I'll show pictures of this. When an invasive melanoma arises in one of these, it is called a lentigo maligna melanoma. Superficial spreading malignant melanoma is characterized by having a radial growth phase where it spreads along the surface, and then the later date has a vertical growth phase where it becomes invasive. Acrolentiginous melanoma is the most common form of melanoma in blacks, and is also mucosal melanomas are also common in blacks. Desmoplastic melanomas tend to be deep and fibrous-like. Nodular melanoma would be just a globular growth. Amelanotic melanomas are those which are not pigmented, and mucosal melanomas can occur in the oral cavity, on the conjunctiva of the eye, and on the anal and vaginal walls. Extracutaneous melanomas occur in the eye and in the central nervous system. Some pictures of these types of melanoma are as follows. This is a picture of a lentigo maligna, and you will notice that it's quite large, encompassing this area is varied in colors with pinks and browns and darker browns. This is a superficial spreading malignant melanoma, and you'll notice that first of all it's very dark and it has a very irregular outline. This is a pigmented streak in a nail, which is called a melanoma striata. In a Caucasian, the presence of a pigmented streak such as this is an absolute indication for a biopsy. It's important to know that in darker skinned people, however, the finding of streaks in the pigmented streaks in the nail is very common. This is another example of an acrolentiginous melanoma. Acrolentiginous simply means on the distal portion of the extremities, and the lentiginous part means they're flat. This little bluish looking area, silvery area, could well be a desmoplastic melanoma. This is a superficial spreading malignant melanoma arising in a large congenital mole. So this was the congenital mole, and this black area with the little, what we call these pseudopods, the little outpouchings, and the slightly different hued color, this is the melanoma arising in it. Diagnosis is by biopsy of a suspicious lesion. Screening, it's important that you understand what normal looks like and what abnormal look like before you can do screening. Normal moles are circular or oval in shape and symmetrical in outline. They are uniform in color. They tend to be 1/4 of an inch or smaller in diameter. They are usually not present at birth, but may appear shortly after birth up until the age of 50 years. They begin as smaller, dark, flat lesions, and with aging they grow in size and generally become lighter in color and more elevated or raised, but they remain symmetrical in color and shape. Abnormal characteristics can be remembered by a mnemonic device of ABCs. It's important that you remember when we're talking about the ABCs, we're talking about something that is changing. The A stands for asymmetry, either in shape and or color. B stands for borders that are funny looking and are either irregular in shape and are indistinct in their terminations. C stands for color variations within the same lesion. D stands for a diameter bigger than 6 millimeters, 1/4 inch, or the size of the end-on view of a number 2 pencil eraser. And E, F, and G stand for something that is elevated, firm, and growing. These latter 3 characteristics are important to remember when you think that you remember that melanomas are not always pigmented. Most people have moles of a similar type. They are called signature nevi, and if one of the patient's moles are different of the type, this is called the ugly duckling sign, and it may be suspicious for a melanoma. It's important to remember that pregnancy, oral contraceptives, and to some extent sunlight exposure cause generalized uniform darkening of a person's moles. Moles and melanomas are often confused with other lesions, such as seborrheic keratoses. These are age-related benign growths that are extremely common. I've never seen somebody over the age of 30 who doesn't have at least one of these somewhere on their body. The older you get, the more of them you get. They vary in color from colorless to very dark black. Here on this, you can see a relatively light one. Here's a dark one. They just are different colors. Because they represent an overgrowth of the outer layers of the skin, they frequently crumble away when they're scratched. They are frequently itchy, and they frequently do get scratched. Here you see one that is very light in color next to this very dark one. This is another example, and you have several, and you can see the variation in color. This is yet another one, and another one which is very dark and alarms people when they see it. This is a benign growth. It's called a lentigo simplex or ink blot lentigo. It looks just like that, as if somebody dropped a drop of ink on the skin. And if you look at them with a magnifying lens, they have a snowflake outline, and they are flat. These are benign lesions called bohinoid papules, and if you only saw one of them, you might be alarmed. When you see a cluster like this, you're pretty much assured that it's something else going on. This lesion very well could be an apigmented melanoma. I'm talking about down here. This, again, would be a distressing finding and could well be a melanoma. Treatment of malignant melanoma is predominantly surgical. Surgical treatment is the only curative treatment for melanoma. All other treatments are palliative. The type and extent of surgery is based upon several criteria. Those are the depth of invasion of the tumor, the presence or absence of ulceration, the amount of tumor cell mitotic activity, and the presence or absence of distant spread, which we call metastases. Prevention largely revolves around sun protection. It's important that areas be protected with densely woven material, avoiding exposure to the sun during its most intense times, which is between 10 in the morning and 4 in the afternoon. Frequent liberal use of sunscreens. Sunscreen should be applied at least half hour before ultraviolet exposure. They should be replenished every 2 hours. They should have an SPF of at least 30. This figure refers to the protection of the B-ray spectrum of the sun. They should also be broad spectrum, sometimes advertised as A plus B, and represent protection to both A and B spectrum. They should be used if you're out of doors for more than a total of 15 minutes on any given day. Remember that exposure is cumulative and additive. They should be used whether it's raining or sunny, whether it's hot or cold. Exposure on an overcast day is still 80% of the exposure on a bright sunny day. They should be of current production, that is, don't use last year's bottle but get a new bottle each year. They must be cosmetically acceptable. If they are not cosmetically acceptable, they won't be worn. They don't do any good in the bottle. They have to be used on the skin. Children need the help of responsible adults. They should be protected with sunscreens. Most sunscreens are acceptable for use on babies and young children. Follow-up for melanoma is forever and should be done at regular intervals. In summary then, speaking of the 3 common skin cancers, many risk factors are preventable by behavior modification. Self-examination and screening by a professional lead to early diagnosis and better result of treatment. If diagnosed and treated early, they are virtually 100% curable. The only certain way to diagnose is by biopsy. Biopsy is simple to do, fast, relatively safe and painless, and need not be disfiguring. For more information, you can call 319-366-7541.
Well, thank you, Dr. Berry. A lot of good information, and the slides were really very excellent for understanding the difference. Now, to remind our listeners, questions can be submitted from the box in the upper right-hand corner of your screen. You can just simply go to the box and type in your question. A question here. Let's get started. We have one question here, and I'm going to read the question. We have our listener asks, I have a couple of questions as I've had basal cell cancer several times on my face. I've had a prevention treatment done in Illinois, and I'm wondering if there is any place in Iowa that does the same procedure. And I'm going to let Dr. Berry pronounce it for cancer. Okay, and she'd also like to know about vitamin A. So, Dr. Berry, do you want to speak to that?
Yes. I do not do phototherapy with Levulan. There are physicians, dermatologists in Iowa who do. If you would call my office, which was that number that was given earlier, I would try to ascertain who locally or at least close by would do that procedure.
Another question about basal cell. Can basal cell cancer be an indent on the skin and not necessarily a growth? This is the listener just recently had a basal cell on the scalp and it was only indented and it itched.
This would fall into that category of basal cells that I talked about, which look like scarring. They can the picture, the visual clues can be very hard to pick up, but yes, the reader is correct. It can appear as a depressed area and not show anything else.
Hey, Dr. Berry, you mentioned scraping off a lesion. So is it okay to pick at a spot on the skin that may look suspicious?
There is absolutely no evidence that physically manipulating any kind of a growth causes it to become cancerous. So from that standpoint, it's safe. As I mentioned, particularly with the seborrheic keratosis, they frequently itch, so patients inadvertently scrape and scratch at them and tear off part of them. That's not dangerous at all.
How important is it to do a body mapping of moles?
Body mapping of moles is sometimes recommended. Technically, it's very difficult and requires special photographic techniques. The difficulties arise because if you get close enough to see the characteristics of the mole, you lose track of where it is. On the other hand, if you get back far enough to show where the person has moles on their body, then you can't see the characteristics that you're looking for. Another complication, if you can think of it that way, of this is that many insurance companies do not pay for this, and it can be very expensive. And lastly, just storing the amount of material. If you see somebody every 3 or 6 months and you take body pictures of all the moles on their body, it gets to be very difficult to store them in such a way that they're meaningfully useful. Above the things having been said, I think this is a valid tool for control of malignant melanoma, and if somebody, a physician, likes to do it and is good at it, why, I think it's well worthwhile.
You mentioned the insurance. Is a referral necessary to be seen by a dermatologist, and then does insurance cover office visits and treatment if it's needed?
Whether or not a referral is necessary would be the personal choice of each dermatologist. So if you call a dermatologist's office, one of the questions you should ask is, do you require a referral? And if they do, well, then you should approach your primary care physician getting a referral. Insurance companies and insurance policies that they sell vary tremendously, and so the patient has to look back at their policies to see what's covered. But generally, examination and treatment for basal cell cancer and the other cancers is covered by insurance.
My teenage daughter believes getting a base tan in a tanning bed is a safe thing. What is your opinion on tanning beds?
Well, there is no such thing as a safe tan. The stimulus for the development of a tan is to damage the skin. Therefore, you can put that equation differently and say, if you got what you did caused a tan, you know you damaged the skin. Remember that all the damage is cumulative, and you're carrying with you all the damage from the first day you were born. My personal opinion about tanning beds is that I tell patients that they're not good for them, and then if they choose to continue to use them, that's their business. Frequently, it's more helpful to dissuade teenagers and young people from using tanning beds to point out that not only do they cause cancer, but they cause a leathery-looking skin and premature aging of the skin and wrinkles. And they may not be afraid of cancer, but they sure don't want to look bad.
Very good point there, Doctor. Related to that, another question, what do you think about spray-on tans? Are they safe?
Spray-on tans are just what they say they are. You're putting a chemical on the skin that either colors the skin or changes the chemical nature of the skin to where it's pigmented. They are safe, and I think they're a very good idea if you want to have a tanned appearance, but yet avoid tanning beds.
That's good to know here. Now, a tape of Dr. Berry's program will be available at www.mercycare.org/live, and just give us a couple days and it should be available to view. You can also check this website for information about future webinars and to listen to past webinars. Our next webinar topic is cancer survivorship with oncologist Dr. Deborah Wilbur with Oncology Associates. The webinar will be Thursday, June 14th from noon to 1, and Dr. Wilbur will take your questions live after her discussion. I believe we have answered all the questions that were submitted to us, but again, remember, if you have additional concerns or questions, Dr. Berry can be reached at the number on your screen, 319-366-7541. Thank you for joining us today.